Good day, friends of Buzzy. Today, I would like to start with a special shout out to my friends Charles and Laura for giving me a microphone that apparently is needed. So we're going to have a nice, loud, legible, audible Facebook Live today. Today, I'm going to talk about three things. The first thing that I want to talk about is coronavirus and science. Second thing I want to talk about is what we know now. And then the third thing is something cool and new to do. So usually I take my mask off immediately, but I want to tell you a little story about when I was in the emergency department and wearing masks most of the time, not as much as we do now. And I would take an enormous amount of time explaining to the families, here's what we know about science, here's why I don't think it's a strep throat that your child has, here's the possibility that it could come back and be a strep throat. We know that 10% of the swabs we do are negative. We do a culture, we may call you back tomorrow or the next day to let you know it's positive, but right now, I don't think we need to start antibiotics, but you could. What would you like to do? And I can't tell you how many of the families, after explaining what is known, would say, just tell me, what should I do? You're the doctor, you tell me. The thing is, people want there to be one right answer. They want one thing to be correct, and they want to be sure. And the deal with science is it's not all black or white, just like the science with face masks. And in fact, what we've got is a lot of gray. I was having an argument with somebody on Facebook this week because they said that the CDC should be disbanded, the CDC knew the truth about masks, the CDC misplaced their authority and was not strong enough on advising for masks and was wishy-washy. Here's the thing. All the way through the 2010s, mask wearing was poo-pooed. It was outside the scientific realm of credibility. There was a study in 2015 that said that even wearing masks for surgery was equivocal. There were a couple different studies that said different things. And so most of the people who are in medicine took what was written and added to it a little bit of bias. If people in Southeast Asia were wearing masks, those people were silly. They didn't understand that it really just didn't matter. And what happened was not a reversal. What happened was not a dereliction of duty. What happened was the understanding and the research has changed. So this is happening at light speed with coronavirus. I'm not going to say warp speed, that's been taken, but we are going through a process of science that typically will take 10, 15 years. I mean, the science continually evolves. We get one idea, we test it, and then if it's better or worse, we test something else and we revise our opinions. So for example, I will be starting a trial with Augusta University next week or the week after, and we're going to be testing nasal irrigation for preventing severe coronavirus. Anybody who's in Augusta, you'll get a piece of paper if you sign up to get your test, and if you test positive and you're over 55, then we will either do nasal irrigation with a little extra bit of alkaline or a little bit of betadine, sort of an A-B test. But the thing is, once we get done with that test, we may still have more questions. We probably will. We will have a lot of different variables. We'll know whether or not there seems to be a better outcome the more times you do nasal irrigation. We may see that one of the two different nasal irrigation machines we're using works better than the other. Don't expect that. We may find that alkalinization and betadine both seem to be better than people who don't even add it. And so there will be more tests. So the answers that we have now are impartial. We are seeing through a filter, and everybody wants right or wrong, black and white answers, but that's just not how science works. One of the things that I have learned that is really important is that the people who are at the CDC doing the research are really deeply digging into what is known, and they don't want to put out anything unless it's absolutely sure. So when they put out the announcement supporting mask use in the first week of April, they were sure. They had a hard time convincing other people politics and habit are just as bad as each other. But from those two things, I will say that we are now at a place where we no longer have what's called clinical equipoise. We're not balanced anymore. We know that mask wearing is a huge difference. So even though I say that with coronavirus, there are very few black and whites, there are a couple. So let's start with the black and whites that we know about coronavirus. We know that it is entering primarily through the nose. We know that wearing a mask is going to protect you if you keep it over your nose. And we know that it protects other people when they are breathing out. What we don't know is what percentage of the time, if any, it goes in from your hands to your mouth to your eyes. We think it's probably not very much. We also don't know for sure whether or not a cloth mask like this is a lot better for protecting other people or yourself than an N95. You would think we would know this. We assume, but we're not really 100% sure. So one of the other things that is absolutely black and white, you will be safer and our community will be safer if you get a flu shot. If you get a flu shot, if you're young in September, older in October, we also know for rock solid certain that 28% of the adult population in this country is afraid of needles. Therefore, a lot of people who usually don't get flu shots, they may say they're afraid, it may actually be that they faint, but we also know for rock solid sure that using a buzzy for the needle for your flu shot decreases the feelings of wooziness that people get, and it's proven to decrease fear as well as decreasing pain. So those things are rock solid. Now, let's move on to things that aren't solid. All right, let's talk about social distancing. People are saying 6 feet. In fact, I believe that last night Trump said that he will wear his mask unless he's going to be social distancing. Well, here's the thing. If you cough, your cough and the respiratory particles can travel up to 18 feet. So 6 feet versus 10 feet or 12, that's actually kind of iffy. There's not a definitive number of feet that makes you safe. Second thing, humans. Man, you cannot trust humans. They will come right up to you. They will get in your face. So even if you are intending to social distance, there is no guarantee that you're not going to have someone run up to you and stick their face in yours and start wanting to chat. So you cannot guarantee that other people are going to have the same feelings and distance perimeter that you do inside your internal safety clock. So let's do a couple other things. I'm going to switch this around so you can see my board. And let's talk about some of the things that are kind of where our ranges are right now. All right, there we go. It's a lecture. Professor Baxter in the house. All right, so CFR, this is the case fatality rate. Where do we think this is? The current actual number in the United States is 3.6% of the people who have a positive coronavirus test have died. But we know that that number is really wrong because there are studies looking down at the percent who have, there are studies saying that the numbers are between 4 and 20 times as many cases. So that would mean that that case fatality rate is divided by 4 to 20. So that would mean the case fatality rate could be 1% down to 0.2%. I don't really think that it's that low. My overwhelming belief on case fatality rate is that it's probably going to end up being 1%. The other thing that's really important for us to remember about coronavirus is that it's not just whether you die or not. There are a lot of, we call them sequelae. The sequelae, the after effects of coronavirus, are a big deal. It's everything from chronic fatigue to lungs that are not working normally, to overall weakness, to risk of stroke, to increased potential for bulbous coronary arteries afterwards. There's a lot of things we just don't know. This is going fast. So I think that the most concerning thing about coronavirus for me is not really the case fatality rate. We know that skews old, and we're pretty comfortable that it's 1% or maybe less. The problem is we don't know whether or not there are going to be problems we have to follow up on people for the next 20 years. So that's kind of where the range is right now. R-naught with the R0, but it's pronounced R-naught. So that is how many people you will spread the disease to. Now this is the one that measles is a 15 to 18, meaning that if you go into a room and you have measles, that if the people there are not immunized, 15 to 18 people are going to catch measles from you. So this high number, each person is going to spread measles. What they say with measles is that if you go in a room and they're not immunized, everybody there is going to catch it, because it is an aerosol virus, it is transmitted quickly, and it's extremely contagious. The R-naught for coronavirus depends on a lot of factors. It depends on the time of year, it depends on the close density of people. If you're living in a place where there's 26 people per kilometer, it's not spreading nearly as much as it is in New York, where there are 240 people per kilometer. So that kind of demographic issue is changing the R-naught. It's not one constant number, and that really matters, because normally if you have an R-naught that is fixed, like for measles, you do an equation and you look at the number of people it spreads to, and that lets you know how many people need to be immunized. So with measles, you have to have 95% of the population who are immune to get to herd immunity. But if you have an R-naught that's 4, then you only need 80% of the population. If you have an R-naught that's 2, then you only need 50% of the population. So the people are talking about what percentage we need for herd immunity. That's another one of these gray areas right now, because the number we need for herd immunity depends on the R-naught. And the R-naught and the characteristics that are contributing to that are not completely elucidated with coronavirus yet. All right. How much will children spread the virus? This is another one that's in hot debate right now. I personally believe that 8 and younger are very unlikely to spread the virus. Why? Because they've got very small noses, they've got very small nasal cavities, and they don't have a lot of expression of ACE2 and the temper gene in the nose that makes them uptake the virus. So if they're not uptaking it very much, they're not going to be spreading it very much. Between 8 and 12 is a little more iffy. Something came out in Korea this week that made it seem like they can spread just as well as adults can. There was one in Denmark, a study that found that only 8% of people who lived in households with children caught coronavirus from their children. Mostly they brought it in from other adults. I think that we're going to end up with a likelihood that there certainly can be cases of transmission from children to adults. It's going to be extremely unlikely in the elementary and younger ages. It's going to become almost normal in the 12 and up ages once they have sinuses and their nasal expression of ACE2 receptors approaches adult levels, but it's still going to be a whole lot less because they're not going to catch it as much as adults do, so therefore they won't spread it as much as adults do. So a little ambiguous, but I think that at the end of the day, most of what we need to worry about in schools is our teachers catching it from the kids. It is not kids catching it from each other. And I think in California, they've got 27,000 cases. They have no pediatric deaths. So I think that the severity in children is much lower. The risk of spread is still lower. And the real big concern for colleges and going back to schools is spreading it to the adults who are teaching people. All right, so what else do we know? So one thing that's in flux is just exactly how much of coronavirus is spread by fomites, which is your fingers, touching stuff, licking things, and how much is spread by nasal aspiration versus oral aspiration. I'm pretty sure it's nasal. But then how much of it is respiratory droplets and how much of it is aerosol? The problem with aerosol and micro droplets, I mean, truthfully, respiratory droplets are also aerosol. It's like it's in the air, so they're all aerosols. But when we talk about aerosol, we're talking about micro droplets that are suspended in the air currents. This really matters because if it's air currents, we need to be opening up our windows. We need to have air conditioner filtration that replaces the air at least 10 times an hour. And it also has big implications on spread and what we do to protect ourselves. Now, I think that you all know that I'm a big proponent of not only nasal irrigation, but also, if I can find it, my highly attractive nasal swim clip that I will use when I go to the grocery store. All right, prop fail. Imagine, if you will, I've got this on my nose. So getting a swimming clip protects you from breathing it in through the nose. But here was my brainwave yesterday morning. So I think we've got fleas. I know we have a cat. I see the cat itching, and my carpet made me itch when I was on it. So I thought, all right, I'm gonna take some flea spray, because it's happened before, and spray it on the ground. Well, we had actually just had somebody visiting the house, so I had opened the doors and I had a fan going. What happened was, as I tried to spray the aerosol droplets of the flea and tick spray onto the ground, even though the fan was not pointed anywhere near me, the turbulence that it gave the air in the room caused the cloud of flea spray to dissipate immediately. I tried again, and it didn't matter how far away the fan was. Even having the fan 15 feet away still was enough to disrupt the air where I was trying to spray flea spray. So now you know that Dr. Baxter has fleas, but you also know that there is the potential for local fan dissemination of particles. If it is aerosol, why don't we get a tiny little fan and clip it to the plastic covering that people have at the grocery store? You know those little stupid plastic fans that they give away for hot weather? The ones, some of them even make little words when you spin it, but those tiny little fans, if you wore it around your neck, that would be enough disruption of airflow to be protective. Now that is absolutely unknown or untested, but there are a lot of implications about if this is aerosol spread that make a difference on how we protect ourselves. So, in conclusion, science is messy, but it is methodical. And every time we do a new study, we test and we move the bar a little bit forward. 5 years ago, we were unsure whether masks made a difference. Now we are absolutely sure that masks make a difference. 2 months ago, we were unsure whether this could spread through aerosol. Now we're absolutely sure that sometimes it does, even though we don't know how often it does. 6 months ago, we thought that most people were getting this by touching their face, touching food, touching particles. Now we know that is very rarely how this spreads. So we're making progress, but there aren't going to be black and white answers for almost any of this. I think that the medicines that we're getting, the different supplements, all the things we've talked about before, nothing has made me think that those are not going to play a part in how we take care of this. But right now, the biggest things we know, black and white, wear a mask, get your flu shot, and try to keep things from going up your nose. It's probably going to be a year, but at the end of that, it's going to be fine. Ta-ta!